This instructional video will demonstrate how to properly insert and administer spinal anesthesia with the patient in an upright, sitting position utilizing a midline approach. Review patient history, make sure to complete the patient assessment, and note patient allergies. Be sure to check patient lab values, specifically platelet level. The lower accepted limit will vary from institution to institution. Ensure the patient has adequate IV access and patient consent has been obtained. Apply appropriate monitors. Properly position patient. The patient can be placed prone, lateral, or sitting. However, this video will demonstrate placement in the sitting position. The patient should sit on the bed with legs dangling off the side. To maximize the space between spinous processes, the patient should arch the back into a C shape. Locate anatomic landmarks by first identifying the tops of the iliac crest. This should be around L4, which is also known as Tafir's line. The midline is identified by palpating the spinous processes. The soft space between the spinous processes is the interspace. Either L3 to L4 or L4 to L5 can be used to introduce the spinal needle. Prepare the patient for the procedure by opening the spinal anesthesia tray. Sterile gloves should be put on, and the patient should be prepared with an antiseptic solution. The solution must remain in contact with the skin for at least 1 minute to be effective, and the dry residue can be wiped away with sterile gauze. Maintain aseptic technique and apply the sterile drape to the back. Re-identify your anatomy. At this point, a rapid-acting local anesthetic such as 1% lidocaine is used for local infiltration of the area just caught at to the identified spinous processes. Raise the skin wheel to place local anesthetic into the subdermal tissue most likely to contain nociceptors. Deep tissues, including the supraspinous ligament, can be anesthetized by spreading 3 to 5 milliliters of local anesthetic through the tissues in a fan-like pattern. Pick up your spinal needle. Larger 22 to 25 gauge spinal needles have sufficient strength for needle introduction without an introducer needle. Ensure that the bevel is up and insert the needle directly midline between the spinous processes and toward the umbilicus. If bone is encountered, the needle is withdrawn and redirected. As the tip of the needle passes through the ligamentum flavum, some compare this sensation to when a needle passes through a pencil eraser. As the needle passes through the dura, the anesthesia provider may sense a pop or a click. At this point, the stylet is removed and several seconds are given for CSF to return through the small gauge needle. After free flow of CSF, aspirate before injecting the local anesthetic slowly at a speed of less than 0.5 mL per second. Incrementally aspirate as you inject local anesthetic, ensuring that you are in the subarachnoid space and that you are not injecting into a blood vessel. Once the local anesthetic injection is complete, the introducer and the spinal needle are removed as one unit from the back of the patient. The patient should be positioned according to the surgical procedure and the veracity of the local anesthetic. It is important to carefully monitor vital signs as spinal techniques block sympathetic nerve transmission in addition to blocking sensory and motor fibers. The sum effect on the cardiovascular system depends on the overall degree of sympathetic blockade, which can cause arterial vasodilation, decreased systemic vascular resistance, venous pooling, and reduction in venous return.